heart disease in pregnancy is rheumatic heart disease. Okay, it's about 56% of incidence is present in pregnancy. So I would like to tell about what are the different classification of symptoms. Like there is one classification known as New York Heart Association has classified the symptoms of the patient into 1, 2, 3, 4. Okay, if the pregnant lady with heart disease, or if any patient with heart disease, if they has no limit for doing physical activity, then it comes under NIHA class 1. If there is having mild limitation, okay, mild limitation in doing these activities, then it comes under NIHA classification 2. In NIHA classification 3, if normal activities, okay, normal activities, if there is if there is a restriction, a marked restriction, there is marked restriction to do the normal activities, it is 3. And 4 comes under normal physical activities. Normal physical activities, if it is absent, then it is known as 4. So that is about NIHA classification. Coming to what are the different risk factors or risks in case of heart disease in pregnancy? They are actually categorized into 3 types of risks, that is low risk, then if it is very intermediate risk, and if it is high, and it can be high risk also. So low risk, what are the different heart disease which comes under low risk? Okay, so if there is any holes in the heart, like ASD, VSD, or PDA. So if there is any VSD, ASD, PDA, then it comes under low risk. Okay, so that kind of person comes under low risk of heart disease. And not only that, if she has any valvular lesions, okay, like mainly tricuspid, okay, tricuspid, and pulmonary lesions. If she is having tricuspid and pulmonary lesions, then it is again low risk. If she is having some valvular lesions and it being corrected by bioprosthetic valve. What is bioprosthetic valve? It is not mechanical, it is organic valve. Okay, so that bioprosthetic valve, if it is been replaced, okay, then it is known as, it also comes under low risk. And if there is any Marfan syndrome, you know what Marfan syndrome, like fibrillin 1 gene mutation, it results in many soft tissue changes. So in Marfan syndrome, if the aortic root is normal, there is no dilatation, okay, then it comes under again low risk. Okay, and not only that, if the patient had some lesions and it been repaired, if there is any repair lesions, it also comes under low risk. So what are the things which comes under low risk? Any holes, any valvular lesions, any bioprosthetic valve, Marfan syndrome with aortic root normal, and repaired lesions. This all comes under low risk. Now coming to what are the heart disease which comes under intermediate risk. Okay, see, something, if you remember low risk, tricuspid and pulmonary, so something the other valves like aortic and other same, like not only aortic, it also comes under pulmonary. Okay, so aortic stenosis, if it is present, then it comes under intermediate risk. So aortic stenosis, if you heard this word, remember this word, because it is very dangerous type of valvular lesion. So if aortic stenosis, it is not normal, okay, it is not low, it is maybe intermediate, it can be high, but it's not that high also, so it comes under intermediate. And pulmonary stenosis, okay, and remember blue, okay, intermediate is blue. So all the cyanotic heart diseases comes under this intermediate risk. And if a lady came to you with a heart disease or with a history of myocardial infarction, okay, it also comes under intermediate risk. The history of myocardial infarction, it comes under intermediate risks. Okay, and I already told, in case of low risk, it is bioprosthetic valve. So in case of intermediate risk, it is mechanical valve. There is mechanical valve place, it is known as intermediate risk. So coming to high risk, I give an acronym known as PCCM. Okay, PCCM is pulmonary hypertension, cardiomyopathy, coarctation of aorta, and M is Marfan syndrome with aortic root dilatation. Okay, so pulmonary hypertension, cardiomyopathy, and coarctation of aorta and aortic root dilatation. So okay, these are all high, moderate, and risks. Okay, coming to a patient, if what are the physiological changes in normal pregnancy, and what is its effect on heart disease? Okay, so in generally in normal pregnancy, heart has many changes. Okay, the plasma volume will be increased. It will be increased. Plasma volume will be increased to 50%, and cardiac output is increased to 30 to 40%. Okay, heart rate is increased to 10 to 15%. Everything is being increased. Only thing is systemic vascular resistance will be decreased, and every other will be increased. So there is more load on the heart in case of normal pregnancy. And if she is all with the she got pregnant and she is also having a heart disease, then it will be more dangerous to her life. Okay, there are some different 5 different danger points. Okay, in pregnancy there are 5 different danger points. First point is at 16 to at 12 to at 12 to 16 weeks of pregnancy. What happens is, during this weeks of gestation, the hemodynamic changes will be starting to occur. So the hemodynamic changes start to develop. So it is one danger point. Another is 28 to 36 weeks. So during this period, these hemodynamic changes will be peak. So that is one point. And other is during labor. In labor, actually cardiac output generally increases to 40%. So in labor, the cardiac output increases so much to 50%. So that also one of the thing. And in during labor, what happens means the uterus start contracting. Okay, the placenta, whatever blood is there, it sends back to heart. So there is more return of fluid to heart, and moreover mother will be pushing down. So when she is pushing down, again heart pressure will be becoming less. So here it is becoming more, here it is becoming less. So there is a variation of fluid or pressure on the heart. Okay, and normal heart can actually manage it, but if it is diseased heart, again heart will be, if she'll land into heart failure. That is one danger point. Other is after delivery. Okay, after delivery also, there is more amount of blood returning to the heart, and the poor old heart can't diseased heart can't take up that amount of blood. Suddenly gushing of blood will occur to heart. Another fifth point of danger point during pregnancy or after pregnancy is 4 to 5 days after pregnancy. Okay, you will sometimes see that pregnant women with heart disease delivered, and after 4 to 5 or 5th day she'll die. Okay, generally most common reason for this for this thing is DIC, or thrombus formation, or pulmonary embolism. Okay, or pulmonary embolism. By what happens is, during heart disease and with pregnancy, she'll start laying down continuously, and all the thrombi will be formed, and after delivery she start mobilate. If she's mobilating, it's okay, and after delivery also, if she lay down and she continuously take rest, then this thrombi which are formed convert into embolia and reaches the lungs. So that is one of the danger point. So okay, if a pregnant lady came to your clinic with a heart disease, so you'll ask her what are the symptoms. Okay, and if she say like she's having edema, if she's having SOB, orthopnea, okay, all those things, then something like left heart failure. And if she's saying that she's having weight gain, she's having JVP raised, and if she's having any epigastric pain, okay, any epigastric pain, okay, and right shoulder pain and all the, and with the edema, with bilateral pedal edema, then it comes under right heart failure. Okay, there is one condition as peripartum cardiomyopathy. Okay, in this condition there is biventricular of heart failure features. Biventricular failure features are seen in peripartum cardiomyopathy. So that's about symptoms. So she came and you ruled out that is heart failure, left or right, then you'll want to go for investigation. What are the different investigations you'll give? ECG, chest X-ray, and echo. Okay, generally echo is normally done. There are different methods like transthoracic echo, transesophageal echo also. Okay, generally these can also be done, which are classical features to find out where is the pathology. Okay, now with the investigations also been done. So you admitted this patient, so you want to give some tips to her what to do and what not to do. We'll ask her not to sit and take rest and not to move not to move vigorously also. So okay, she should have a intellectual way to manage her rest and her activity. She should restrict the activities more if she's doing, and she should not take more rest also. Okay, that thing. And we should actually increase her renal perfusion. Okay, we'll ask her to take water. Okay, not more fluids, we'll ask her to take water, and she should not have renal failure. Okay, not only that, we'll ask her to restrict the salt restriction. If it is done, then retention of fluid will be decreased. Okay, retention of fluid will be decreased, and heart also doesn't have this preload type of effect. Okay, that's about this thing. And if she's having any congenital heart disease, if a pregnant lady with congenital heart disease came to your clinic, and she will compulsory will be on anticoagulants, then you'll ask her to take these anticoagulants continuously. Okay, if a pregnant lady delivered through vaginal delivery, then after 6 hours you'll start her on anticoagulants. If by cesarean section, then after 24 hours you'll start her with anticoagulants. Okay, in vaginal delivery there's about 400 to 500 ml of blood loss. In cesarean is about 800 to 1000 ml blood loss. So ml of blood loss also should be kept in mind. So this is about different symptoms, different investigations, and different management in case of heart disease with pregnancy. Okay.